All right, welcome to another episode of ICU Doc Talk. Thanks for joining in today. Today, what we're going to talk about? We're going to talk about how to keep people out of the ICU. I got this idea from a listener who emailed me with a great email. His name is Mark, last name withheld, and I'm just reading little snippets of his email here. He said a good topic I think of is how to keep people out of the ICU, via earlier or more aggressive initial intervention, etc. This is a really great topic. I love this topic. Let's talk about it. How to keep people out of the ICU from coming to, someone like me who takes care of them. It's a rich topic, so there's a lot to do here. Just real quick, this guy who emailed me also mentioned that he loves Brandon Sanderson, The Way of the King series, which really elevated this listener in my mind because I'm a huge Brandon Sanderson fanboy, as is like half the fantasy world. All right. Anyway, so yeah, let's talk about this. So one of my jobs as a intensivist, physician who works in critical care, one of my jobs is to triage patients in and out of the ICU. Right. I get called or consulted all the time when I'm when I'm on the unit, meaning when I'm doing my role as intensivist, to come assess a patient. Or maybe just to look at their chart, or sometimes I'll call someone will call me from half the country asking about a transfer, being a candidate for ECMO and things like that. Anyway, I do a lot of triaging for the ICU. So I have a lot of experience knowing, like, okay, does this patient need to come to the ICU? Or yes or no? And I think one thing to make clear, and I sometimes explain this, I hope I'm not too condescending, but I sometimes explain this to patients and often surgeons, that the ICU is not good for you. So what I mean by that is, no, you should not be admitted. Now there's exceptions to this, but you shouldn't be admitted just in case something goes wrong. And there's tons of it. I'll qualify that a little bit more. Like, general paranoia should not be oh, we want to watch them overnight. Well, okay, what's the exact reason? What did you just do to them? Talking to like a surgeon or proceduralist, like what did you do that needs to be watchful? Well, nothing in general, we're just paranoid. Okay, so paranoia of a surgeon is not a reason to admit a patient to the ICU. I'll just say that right off the bat. That is not a reason to admit a patient to the ICU. And I will reject patients coming to the ICU all the time, often pissing off surgeons, but it's like, I don't care. And my point is, the ICU is not good for you. It's not a place for the human body. Okay, it's not good for you. Having alarms going off constantly, having a nurse checking in with you constantly, having your vitals taken, having labs drawn for whatever reason, getting an X-ray in the morning, having your sleep interrupted. Even if you're a normal, healthy person, this is not a fun place to hang out. And then if you're sick, but you don't quite even need the ICU, and if you don't need that level of monitoring and care, you shouldn't go to the ICU. Okay, so I'm going to start off the discussion with that. The next discussion is, the ICU should not be used as a procedural suite. And what I mean by that is, I'll get calls from whoever, a pulmonologist or a GI doc or whatever, who they call and they say, hey, look, I have a patient that the ORs are booked or the procedural suites are booked, but this patient needs a bronchoscopy, which is a fiber optic camera that goes down into the patient's lungs. You clean out, you do biopsies, whatever. I do them all the time as well. And can we admit this patient to your ICU to do the procedure? And then, I'll ask some questions like, well, how are they doing right now? Oh, and if the patient's fine, like they're clinically fine, there's nothing urgent. It doesn't need to be done emergently. If it needs to be done emergently, that's a different story, right? If it's just urgent and it's just to make their schedule better, I often will say no. That's not a reason to bring the patient out of the ICU. Now, having said that, I also recognize the reality. If I have a surgeon that says, hey, I want this patient to have a bronch, and I look at the patient's chart and I look at the operating board, and it's a Friday, and I can see that this patient will not get this procedure until Monday, the best thing for them is to bring him to the ICU to get the procedure done for the patient. So I will do it in those cases, because it's like, I want this patient to get this procedure. I know it's not emergent, but I want them to have this thing done. It's the best thing for them, and it's the best expedited care. And then fully knowing that it is a terrible waste of resources. Using an ICU bed for something like that is a terrible waste of resources. It's extremely expensive, and it's occupying an ICU bed, and it's using up ICU staff for non-ICU needs. So anyway, there's a reality as well that I know I must face, and I do recognize that as well. Okay, so that's kind of off the top of my head. Now, so there are, let's see where to take this discussion. There are systems in place to detect if a patient deteriorates and then needs to come to the ICU, right? There are systems in place. Usually in the United States, at least, and most universally, they're called rapid responses, or RRTs. So when a patient is not in the ICU, say they're on the floor, meaning they're in a medical or surgical ward, they're getting lower level care. What I mean by that is not lower level care is a bad term, I guess, right? It's not like a lower standard of care. It's not as intensive monitoring, right? A nurse checks in, does vitals, not as often, and you just don't need monitoring in labs and stuff like that as often. And obviously, you don't need anything invasive to keep your body alive. So the RRT exists for a reason. So if someone deteriorates, like overnight, so they have a bad vital or something, they're suddenly hypotensive, a nurse can trigger the rapid response. And there's a dedicated 24/7, and this is most hospitals, right? Maybe not most, I don't know, you can email me if I'm wrong. And the nurse can trigger the rapid response team, which is a team of nurses, and sometimes it's a resident in the academic center. Maybe there's a physician there, maybe there's not, whatever. And they come and assess the patient. They take vitals again, maybe they need an IV. And then they call someone like me to be like, hey, I think maybe this patient needs to come to the ICU. Great. Okay, that's what that system is in place for, is to be able to do that. So you can safely, if a patient has normal vital signs, right? And what do I define by normal vital signs? Well, not being hypotensive despite treatment, right? So if someone is still hypotensive, let's say, I'll just throw out a kind of a random number, say if they're still 80 over 50 or something, with a MAP of 60, despite 2 liters of volume resuscitation, right? Normal saline or lactate readers, whatever it is. And they're still kind of hypotensive. And then maybe they're a little tachycardic on that, right? Maybe they're in the 110s. Okay, all right. Let's bring that patient to the ICU, because they may deteriorate and they may need pressors. Now there's some hard cutoffs I'll get into in a second where you automatically bring a patient to the ICU. By the way, it's impossible for me in this podcast today to discuss all of the myriad reasons someone can come to the ICU, right? There's many, many, many reasons. I'm going to gloss over many of them. Anyway, so the rapid response, these things are in place. So a classic scenario, I'm sorry if you're a urologist, okay, but I got a beef with you. This is so classic, I can't even believe how classic this is. Okay, someone will come with a kidney stone, and the kidney stone gets broken up by a urologist, which is awesome. And the patient's vitals are fine. And then they're in the operating room, and then they come out of the operating room. And so I can't tell you how many times a urologist will call me and be like, I want to monitor this patient in the ICU in case they go septic overnight, because that can happen. You break up someone's their kidney stone, and it can release bacteria that was building up there, and it can go to their bloodstream maybe, and they can become very sick from it. That can totally happen. I say no to these admits. If the patient is currently fine, they're not acting septic, they can go to the floor. And here's my further answer to that. You can be septic on the floor. You don't need to be, if someone has sepsis, let me be clear here. If someone has sepsis, meaning maybe they have a rising lactate, they've proven bacteria growing in their blood, they're on antibiotics, right? Maybe their heart rate is a little high, but their blood pressure is fine, and their white count is high. Like they have sepsis, and they have a fever. You can stay on the floor. You can stay in a medical ward. You can stay in a surgical ward safely. It's when you're in decompensated septic shock that you need to come to the ICU. So unless a patient is in decompensated septic shock, they should not come to the ICU, because there are systems in place like a rapid response that if that patient is septic and they're on the surgical ward and they suddenly become hypotensive, then okay, bring them to the ICU. Now, there are exceptions to this, right? If I talk to the urologist and the stone was really gnarly and they're really, really concerned, I'm not unreasonable, right? Like, if you know my personality and you know me from TikTok, I'm not like I'm a reasonable person. You can have a conversation with me, and I can come to a compromise, right? And I am happy to be a pushover. I do not care about being if someone's really adamant about something and they really are pushing me, I'll be like, okay, fine, whatever. I'm gonna move on with my day. I can't waste my time. Like I'm totally fine being a pushover. It's okay. Which I think is a good lesson. Like, you don't need to be like a hard ass all the time, admit it. Like, it's fine. Just be a pushover. Who cares? So I will be a pushover. It's fine. Sometimes it's too exhausting. Like if I'm in the ICU and my day is so exhausting and someone's like, hey, can we bring this patient? And they have somewhat of a good case. And I'm like, man, I just got to get on with my day. I can't argue with you about this. Like, okay, bring your patient, watch them overnight. It's fine, whatever. Like sometimes I just got to do that because I don't have the cognitive load to debate with somebody about coming, whatever. And it's just not worth getting an argument and having bad feelings with people. I just don't, that's not how I like to operate. So I know I'm like painting myself as some sort of hard ass right now, but I'm not. Okay, anyway, so urologists are like super big culprits of this. And I often will be like, look, here's my compromise. If say this patient's in the operating room, I'll be like, let's send this patient to the PACU, the post-operative recovery unit. Let's see if their vitals there, for an hour or so. And if they don't act septic, let's just send them to the floor. And if they do, they can come to the ICU. It's why we have rapid response. So that's just one of my main points. There's a system in place to detect people that decompensate. So what is decompensated shock? What is the reason that people come into the ICU? Okay. Oh, I'm asking too many questions. There are some no-brainer things coming to the ICU, right? If someone has a breathing tube, right, they're on mechanical ventilation, obviously they're coming to the ICU. If someone is on pressors, in the United States we call them pressors. What I'm referring to that as vasoactive drugs like norepinephrine, epinephrine, vasopressin, or angiotensin II, of course, phenylephrine, in Europe, adrenaline or noradrenaline, right? Any of these medications, if you're on a drip, you're coming to the ICU right away. Because there's many reasons for that. That's an automatic admit to the ICU. Because number one, it represents this patient's unstable, number one. And number two, these are dangerous drugs that need to be administered by experienced ICU nurses, right? ICU nurses, that's another big point here. Man, this is a big topic. I have a lot. I could do 2 episodes on this. ICU nurses have different training than a floor nurse, right? They're different training with different drugs and many different things. That's a whole another topic that I'm not even knowledgeable enough to speak on, right? Because I'm not a nurse. But it's a completely different skill set and training. So to manage these drips safely in a safe manner, because these are dangerous medications. If a medication error is made with like a bag of concentrated epinephrine that's hanging and slowly going in through a pump, it could kill someone, right? So there's things like that. Okay, so breathing tube. Okay, if someone is bleeding, like if they're getting ongoing resuscitation, like if they're getting blood products, of course they're coming to the ICU. They need that ongoing resuscitation. There's so many other reasons that is automatic admit to an ICU. I will say one thing that is not an automatic admit to ICU. If someone has an elevated lactate but is otherwise normal, that person does not need, otherwise normal vitals and stuff. That person does not necessarily need to come to the ICU. They're probably, maybe they have a little. So a lactate is when someone's body goes into anaerobic metabolism because their oxygen delivery to their system is going off because they're in septic shock, or maybe they're approaching septic shock. But if they have an elevated lactate level like 2 or 3, but they're otherwise fine, you can send that patient to the floor and see how they go. You've probably treated in the emergency department. Their sepsis has been treated and they're coming off of that, and they're probably coming down from it. So a slightly elevated lactate is not a reason to, in my opinion, to just admit someone to the ICU. There's so many reasons that are automatic admits to the ICU. It's like it's hard to know where to even begin. But I mean, we can just stick with those ones: bleeding, clear bleeding, decompensated septic shock, meaning your body is no longer compensating with your blood pressure. So let's talk about vitals. So low blood pressure, right? Refractory low blood pressure, meaning it's not responding to treatment. They're coming to the ICU. Tachycardia, 110, 120s, even if it's normal sinus. Just that alone, patients should probably come to the ICU. There's a reason someone is tachycardic. Severe alcohol withdrawal, needing lots of benzos and sedation. Problems with sedation is a reason to come to the ICU. Severe delirium, where you're needing like really substantial levels of sedation. These are reasons to come to the ICU, for sure. And then post-procedurally, to watch someone overnight is a reasonable thing particularly if you've done something invasive to them that you need so more often vitals, right? Let's say someone has brain surgery and they need the surgeon wants out vitals every hour, like a neurological exam every hour to detect for brain bleeding. That person needs to come to the ICU. You can't have a floor nurse doing vitals every hour. That's an ICU thing. So needing more vitals, like more often, like Q 1 hour every 1 hour, or needing more labs, right? Say someone was hyponatremic. This is a classic one. Someone walks in the door, they have a sodium of 110, but they're otherwise fine. Their vitals are fine. Oftentimes they do need to come to the ICU because you need to draw labs more often to make sure you're not overcorrecting their sodium as you're providing therapies to bring up their sodium, whatever that may be. There's many ways to do that. So often lab draws, often vital checks are reasons to come to the ICU. And then if someone has a vascular procedure in their groin and they need to hold still for 6, 8, 12 hours, whatever, something like that. So there are, they can come to the ICU. There are post-procedural reasons to come to the ICU. And then anytime there's some surgeries that if you get this surgery, even if everything went fine, you automatically go to the ICU for observation. One of those is cardiac surgery. If you get cardiac surgery, doesn't matter what it is, you're going to the ICU after post-operatively. Regardless. And that is a good practice, right? Because this is a very invasive procedure, whatever it is that a cardiothoracic surgeon did to you. And you need to be monitored because things can go wrong afterwards. You can bleed. Many things can go wrong, and you must have intensive monitoring. Oftentimes, patients can go out to the ICU the next day. The vast majority of cardiac surgical patients, they get observed in the ICU overnight, and they go out of the ICU the next day. At least in my practice. That may vary from practice to practice. Okay, so pain control. If someone takes a bunch of pain medications at home, a lot of opiates, and they need a lot of high level pain control, that may be a need to be in the ICU. If someone needs a ketamine drip, although you can have ketamine on the floor depending on the institution. But if they're needing a lot to titrate things off, and it's really labor intensive for nursing staff to provide that, or if they're on opiate drips or something like that, then they need to be the ICU. Just that alone is a reason. Other things, urgent dialysis, emergent dialysis, putting on a line someone because they missed their dialysis 3 days ago and they have a potassium of 7. Yeah, bring them to the ICU, of course. This is just like a grab bag, right? There's all these reasons people go to the ICU. So let's focus on how do we keep patients out of the ICU? How can we prevent them from needing admission to the ICU? Well, first off, is one of the reasons I've been talking about this whole episode is appropriate triage. If a patient, number one, if a patient is appropriately triaged, then that safeguards patients from being admitted to the ICU. What do I mean by what's triaging? It's figuring out what level of care a patient needs. So this triaging starts with emergency physicians, right? They are experts in triaging patients. ICU physicians or staff, right, like myself. But also just any kind of physician, any sort of healthcare worker, appropriately triaging and understanding where the need, what level the patient needs. So patients are inappropriately triaged all the time, right? So people can be admitted to the ICU when they don't need it, or or the opposite. They're admitted to the floor when they really should have gone to the ICU to prevent an emergent admission. I would much rather have a semi-urgent admission to the ICU than crashing someone into the ICU. That's that's preferable. So someone getting timely therapies upon admission to the hospital helps prevent crash admissions to the ICU. Whatever it's, and this is it's such a big topic, but whatever those timely therapies and interventions and testing to figure out what's going on quickly and to institute those things in a timely fashion can prevent someone from decompensating and then needing the ICU. So back to rapid response. Don't be afraid to call a rapid response. So if you're a floor nurse listening to this, never feel bad about calling rapid response ever. I don't care. If something's going on and you're not comfortable with how the patient's doing and you're worried about the patient, call a rapid response. So I'm a person that shows up to rapid responses, or residents do, whatever. And it's just if the rapid response team if that team judges you for calling the rapid response, that's on them. Who cares? It doesn't matter what the opinion is. If you are worried that the patient is decompensating and they're having, even if their vitals are not even that bad, but if they're maybe you're worried about signs of stroke or something like that, yeah, call a rapid response. That is why it's there. That's why it's there. Do you know how many times I've gone to rapid response and we decided to leave the patient there? That's the typical, right? And one thing that one point of the rapid response team is not just to triage the patient; it's also to institute therapies, and then leaving the patient where they're at in the ward, and then following up with the patient. Right? It's getting rapid intervention right there. It's not just to triage to the ICU; it's to get an intervention. Right? So a classic example is like a patient's little blood pressure is a little low. So the rapid response team comes and they get a little bit of fluid resuscitation, and then they get better. And then, okay, well, we'll see how they do. And they don't need to go to the ICU, follow up. And the rapid response team, I always try, so if I go see a patient in the ward, surgical or medical ward, and I've been called there to see if the patient needs to go to the ICU. Someone, whether it's the bedside nurse, the charge nurse, or a family member, they've been worried enough to call me. So they're concerned. And if from my standpoint, I don't think they need to come to the ICU, I establish a very firm plan. If I'm going to keep that patient on the floor with them in the wards, I establish a very firm plan with the care team. I say, okay, hey, look, we're going to try this, and then if that doesn't work, if this happens again, call me, and then we'll bring the patient to the ICU. There needs to be a very well-described plan, and everybody needs to have buy-in. And I check in when I'm saying these things. I say, is this okay with you? To the nurse, to the bedside nurse who is going to continue taking care of the patient. Or I say this to the charge nurse and the patient's family member. I'm like, here's the plan, let's do this. I'm like, is everybody okay with this? I make sure that they're legitimately okay with it. If I sense hesitation, because sometimes, in the unfortunate power hierarchies that exist in hospitals, sometimes when a doctor says something, a nurse may be afraid to speak up, but I can read it in their body language if they're not comfortable with my plan. And then I'm like, okay, is it not okay? What do you suggest if you're not okay with this, what should we do? And if they push back again and they're like, no, I think the patient come to the ICU. As I said, I'll be a pushover. It's fine. I'll be like, you know what? I can see, after a discussion like this, if I can still see that people are not comfortable with the plan, even though I don't think the patient needs to come to the ICU, but if everybody's like, we would really be more comfortable with this patient in the ICU, I'll be like, okay, it's fine. We had the discussion and people didn't, not everyone was on the same page. I want everybody to be on the same page. I don't want to unilaterally make decisions, right? I want to respect the clinical decision-making and judgment of all healthcare workers and also the patient and the patient's family. So it's fine. If people don't agree, then it's fine. Let's bring the ICU. What's my whole point with this? Anyway, the rapid response team is there to institute therapies and to establish a plan going forward if they're not going to take the patient to the ICU. So you should demand that. If you're not part of a rapid response team and say the rapid response team is like, they're fine, bye. You should, if you're the bedside nurse, you should be like, wait. So what's the plan then? There should be an established plan that everybody agrees on to make sure the patient is safe to stay on the floor. Now, here's another thing. So patients can genuinely be deteriorating on the floor, but it's being masked by something else. Let me think of an example. So let's say, here's an example. Let's say a patient uses BiPAP at home for their sleep apnea, and they're now admitted to the hospital, and they use BiPAP at night in the hospital as well. But now, let's say a rapid response is called, because maybe the patient wasn't very arousable, and it's 2 p.m. It's the middle of the day. The patient doesn't use BiPAP during the day, but the patient is on BiPAP now, and they're doing fine on BiPAP. To be like, oh, okay, they're good. Like, no, there's something new going on. They're in new respiratory failure, even though they're on the same BiPAP settings they use at night, and now they're using it during the day. That's new respiratory failure, and that patient should go to the ICU. If you just be like, oh, they're good on their normal home BiPAP settings and leave, you're missing something. You're probably missing something. Like something's going wrong. Another example is like, oh, here's a perfect example. I've seen this many times. So I come to a patient's room, say they're delirious. Like, okay, they're agitated, delirious. Please come help. So you go to the room, and the patient's just agitated out of their mind, right? They're thrashing the bed, they're screaming, they're yelling, and then you give Haldol, right? Haloperidol, which is it's an antipsychotic, it's a sedative, which is a great tool for agitation. I'm not saying that we shouldn't use that. And then you give that, and then what happens? Well, you give the Haldol, and they, get sedate. And you're like, okay, I guess it was just agitation. Good, all right, they're great, let's go. No. Why are they delirious? There's something new going on. You can't just give them Haldol and walk and be like, okay, they're good. There's a reason they're delirious. And one of the reasons someone can be delirious and hyperactive is they're hypercarbic because they're not ventilating enough, because they have too many opiates on board. It's a lesser known fact about opiates. Okay, so opiates do sedate, right? They sedate you and they drop your respiratory drive, right? We all know that. That's how people die of opiate overdose. Well, what can happen, doesn't always happen, is that someone's ventilation gets worse and they're not breathing very well, shallow breaths from opiates that they're getting, that we're administering to them for pain control, as their carbon dioxide starts to climb in their blood, right? As your carbon dioxide starts to climb, you actually can become very agitated and delirious with really high hypercarbia or high carbon dioxide. And so if you just come and mask that with Haldol, you are definitely making things worse. And that's a very dangerous situation. So what I'm saying is you need to appropriately rule out all of the bad things before you just give something and that masks the underlying cause of what's going on, if that makes any sense. And that hypercarbia is a classic one. That's a classic one. It's sometimes it's not understood that no, severe hypercarbia can actually arouse and agitate people and make them act very delirious. And if you just give them Haldol, you got to look, like, are they getting opiates? Look at their eyeball, look at their pupils. Are they pinpoint from all the opiates? You got to do these things. And then speaking of drug opiate narcosis. So in my opinion, if someone gets a little too much opiates on the floor, right? They have respiratory depression, and then a rapid response is called, and that requires Narcan, which is the antidote, right? That reverses it. As soon as you reverse it, if from a bolus and they're not on like high dose opiates, if they're pretty clearly awake and breathing, you don't necessarily need to bring that patient to the ICU. Not necessarily. You got to make sure that you got to assess and see how they're doing. If they have so many opiates on board that you need to start a Narcan drip, then of course they need to come to the ICU. But that's not an auto admit to the ICU, in my opinion. Giving some Narcan on the floor. But of course, that's not. You can't apply that statement to all cases. That's a case by case basis. All right, and then I think this is going to sound, maybe a little contrived or whatever, but the way to keep a good way to keep patients out of the ICU is to listen to patients. And I know it's like beating a dead horse and all that stuff, but I honestly think patients. So, do patients have intuition about their health, about decline, about them clinically deteriorating? They may, but like some sort of patient intuition. People have a good idea about the status of their body. Now, I do mean that in kind of an ethereal way, but to contextualize that a little more. Patients are the only ones who understand and have a feel for the longitudinal course of their disease, right? Patients and their families, sometimes their families, they've been there the entire course of their disease, right? See, someone has cancer. They've been there the whole time. Now, they've had many different healthcare workers and doctors and nurses and NPs and PAs, but that's all interrupted, right? What I mean is patients understand their longitudinal course. And if patients are like on the floor or whatever, or they're in your clinic or they're in urgent care and they're like, something is wrong with me, like I'm not feeling well, so I don't know what it is, what does it hurt to do an extra diagnostic test or an extra lab that maybe you don't think is indicated, but they are insisting on it? Do it, get it, just see. Now, they may not be right, but sometimes they are. And maybe it's just a coincidence. But I don't know. What I mean is, if patients feel like something is wrong with them, that they're getting worse, they oftentimes are right. They can feel it. They are living in their bodies, with their disease, and they can feel it. And I think it's an important thing to keep in consideration. I know it's kind of like a hand wavy thing, but anyway, I'll leave you with that. All right, let's move on to a book. Nonfiction book for this week was phenomenal. It's called The Shadow Docket. It's by Stephen Vladeck, Vladeck. It was written very recently. It was published May 16th, 2023. And it's 350 pages. This book, so I'm not a lawyer, right? And I have very little experience with constitutional law. Like I barely took any political science classes, and I'm not a person that has a lot of experience. And I don't understand constitutional law. I'm not going to claim to, and I don't know how the Supreme Court, fully functions. And that's why I picked up this book, The Shadow Docket. It's about the Supreme Court. I found that it was really accessible, and it's good for an audience like me who's groping in the dark about how the court functions and the latest, controversial rulings. The main thrust of this really timely book comes down to the difference between the merits docket and the shadow docket. I'll give a crude explanation, as far as I understand, about how these two dockets work. The merits docket is what the public is used to. That's like when you hear that the court hands down a decision with like oral arguments and opinions, and there's dissents given and all that stuff. So all the landmark decisions you can think of likely come from the merits docket. The shadow docket, on the other hand, is basically the court making a decision or a non-decision about lower court or state law while offering no written explanation for scrutiny and allowing the judges to hide how they voted. So it's anonymous, their decision. The shadow docket decisions are traditionally rare and are used for emergency decisions like a stay of execution, of someone who's on death row. The problem that the author demonstrates very well in this book is that the shadow docket's use has accelerated over the last 10 years and is clearly tinged with political ideology, and it diverts the court's attention away from the merits docket. So the author believes that the use of the shadow docket all started with President Taft, the only person to be president and also to sit as a justice on the Supreme Court. Taft gave the court more discretion about running their own agenda. Rather than being the final decision, like the final decision court, the Supreme Court, it had much more autonomy to set its own agenda after Taft. The Judges' Bill of 1925 helped bring in more Supreme Court autonomy about the cases that they would see. But it actually wasn't until, according to the author, it wasn't until 1988 that the court finally had full discretion over its docket. Judges started to pick and choose what cases they wanted to review, and even only pick a question from a case and to answer in a highly selective manner. Soon the justices were even writing their own questions to answer. So what I picked up from this is that the court shifted from being beholden to deciding cases to having total discretion over the cases that it chose to see. For me, as I was reading this, the problem became very apparent. The court has basically become like a de facto autonomous legislative branch, right? When it's supposed to be judicial. When it can decide what cases it wants to see and what it won't even see. It is the very ability to deny or see a case, which is called certiorari, that state law and lower court decisions can become enshrined into law because the Supreme Court has the autonomy to deny even reviewing a case. And then when you combine this court autonomy with the anonymity of the shadow docket, you indirectly have a concentration of unelected judges making legislative decisions with zero public accountability. This is the modern day function of the shadow docket of the Supreme Court. Sounds bad. The impact of the Supreme Court autonomy is tremendous. The court can inexplicably contradict itself with the shadow docket, like a differential stay of execution based on someone's religious background. Literally, whether someone was Muslim or Buddhist, this happened with zero explanation because it happened on the shadow docket. More recently, the court guaranteed 3 House seats that would have gone Democratic in Alabama in the 2022 midterm elections. But they voted Republican because the shadow docket refused to put an injunction on gerrymandering laws. The use of emergency decisions has seen a sharp upturn on cases that aren't really emergencies at all. Trump's Solicitor General sought emergency release 41 times compared to only 8 times combined under Obama and Bush. There was an unprecedented use of the shadow docket and emergency use to prohibit California and New York state laws that prohibited large religious gatherings during the COVID-19 pandemic, only made possible by the addition of Judge Barrett. There is a flagrant hypocrisy of the conservative judges who wanted to stop mail-in ballot voting during the pandemic because it was too close to the election, evoking something called the Purcell Principle. But then they did absolutely nothing to stay an injunction in Florida that would help 1 million ex-felons vote to be able to vote when that state law passed close to election as well. So to reiterate, they tried to strike down mail-in ballot voting because it happened close to election. But when Florida made a law that ex-felons had to pay a bunch of money to be able to vote, which is basically a poll tax, the Supreme Court was silent, right? So it's a clear partisan thing. Perhaps maybe these are false equivalencies, but when you stand back and look at the emergency use and the Shadow Docket, as this book does, it all clearly leans conservative and helps Republican state and federal politicians. It's pretty undeniable. But all of this occurs on the Shadow Docket, where not a single oral argument or opinion is even issued. So the author's main point is that the increasing use of the Shadow Docket for partisan de facto legislation totally undermines the court's legitimacy as an impartial judiciary. The author asserts that, as well, it's well within the purview of Congress to reform the Supreme Court. He states that Congress should force the Supreme Court back onto the merits docket and totally reform the Shadow Docket. Seems like a good idea to me. From my perspective, one of the issues is that the court simply isn't large enough. The entire argument to use the Shadow Docket is predicated on the assumption that there are only 9 judges to go around, so you can't waste all their time on only merits dockets, or else everything will grind to a halt. So what is the solution? Expand the Supreme Court. Done. Anyway, great book. I highly, highly recommend it. It's called The Shadow Docket: How the Supreme Court Uses Stealth Rulings to Amass Power and Undermine the Republic by Stephen Vladeck. It's phenomenal. It's a must read. All right. So I'll move to another book. I'll do a fantasy book or sci-fi. And if you're not interested, you can hop off, have a good day. And if so, stick around and I'll talk about another book here. All right. I'm going to talk about one of my favorite science fiction books of all time. It's called Hyperion by Dan Simmons. This was written in 1989. It's about 500 pages. So as a huge sci-fi and fantasy reader, I thought I had a pretty good grasp of what science fiction was capable of, but this book totally blew away my expectations. I don't even know how to begin to talk about this book. I could start with, like, it has masterful subverting storytelling or bottomless well of characterization. Hyperion has so many things. And above everything, it's a story about time and love and regret and horror. I guess it's a space opera. Seriously, I don't even know where to begin. So I guess starting with the prose, it's amazing. Simmons, the author, really cuts the fat, describes what needs to be described without being indulgent. He instantly can create an entire planet, shade it within a culture, and then place the character set pieces to engage with that setting. He's economical with his words when he needs to be, and then layers in pretty words with really impeccable literary timing. The dialogue is real. The scenes are framed perfectly. Hyperion it's at one time a single story, but it's also separate vignettes like Canterbury Tales. Clearly it's mirroring Canterbury Tales in a space opera, each contributing to one another and the overall arc of the story. If at first you don't think you like this kaleidoscope storytelling, it really works. You just wait. It really comes together. The world building is enormous, and there's many worlds in this. Without info dumping, he unfurls this sprawling intergalactic hegemony where humanity spans dozens of planets, many thousands of years in the future. Of course, he's not the first to do this, but here's what he achieves. He makes this future social construct of humans actually feel familiar. And he does that because he leaves vestiges of old Earth, like current-day Earth, littered throughout the story, from poets like Keats to common world religions, including Christianity, Islam, Judaism. The degradation and transformation of these modern-day cultures is really just fascinating. Catholic priests are still around in this world, but they're not up to the things you might think that they are. The book is full of prophetic dreams and visions that bring a welcome mysticism, and it really hangs beautifully over this hard sci-fi backdrop. The world building is really subtle. It comes in at different angles. It doesn't slam the reader with rigid boundaries. The building is organic. There's one thing that he does really well. The fancy sci-fi world building isn't just a gimmick with a flimsy plot. The world building isn't even what makes it so good. There's so many amazing sci-fi elements. There's time travel and relativity and entropy and reverse aging and space travel and multi-planet governments and AI overlords, robotics, secession, cyberpunk, time travel. There's alien space battle. There's just so much. It works. It really works. There's so many things this book is. It's like a romance. It's a tragic romance. There's a trans-robotic romance. It's a noir. It's a slasher film. It's a psychological horror. It's a requiem. It's a story about revolution. It's a story about imperialism. It's a political thriller. It's a writer chasing his muse. There's so much. You wouldn't think that throwing all these elements together would work at all, but it totally does really, really well. Above all, Hyperion is simply just a beautiful book about a group of strangers on a mysterious pilgrimage whose past lives not only inform the ongoing plot, but serve to enrich the characterization and the character dynamics. I've never read anything like this. And I consider it a masterpiece. And the follow-up book, The Fall of Hyperion, is just as good. You got to read the first and second. The third book kind of fell off for me. It's a 4-book series, but I read the first and second, loved them, and the third book, a little bit lower quality. Still good, but it kind of falls off after that. Anyway, I highly recommend it. If you're a sci-fi fan, Hyperion by Dan Simmons. You've probably heard of it. It's a big book. All right, anyway, I'm going to wrap it up. Thanks for listening. Follow me on TikTok. It's ICU Doctor. Instagram, ICU Doctor TikTok. Email me at icudoctorecmo, ECMO, @gmail.com. Please give me ideas for podcasts, like the gentleman who gave me this idea. And it kind of makes me record an episode. All right, have a good one.